Hello guys, this is Jamin Singh Rao and welcome. We are going to discuss about the Parkinson disease and types of hemiplegia and motor disease that are very much discussed in the video. So let's start with the one disease that is Parkinsonism. So I will share one slide and this slide will be discussed in this. First of all, begin with the you can watch motor disorder. Hello guys. So begin with the what are the controlled by extrapyramidal system. So there will be a hyperkinetic, hypokinetic. So what the disease that comes under the hyperkinetic. So this slide is showing that hyperkinetic means chorea, athetosis, hemibelismus, dystonia. These all are conditions which come in the hyperkinetic. So our aim is to discuss about the hypokinetic, that is Parkinsonism disease. So guys, as we know that Parkinsonism is a type of disease that comes under the slowness or paucity of movements plus no evidence that is known as a Parkinsonism. One second, keep on hold. There will be a one confusion. You can hear me properly. So that's why I was many times there will be a difficulties in online session. So continuing this Parkinsonism disease, so hypokinesia, where the um, slowness or paucity of the movements takes place with no evidence of weakness and spasticity. So as you know that usually Parkinsonism is a disease which takes place after 60 years of age. So old men or old, that is old patient will be more commonly present. It doesn't determine that the young patient is not affected. Young patient is also affected, and young patient is also responsible for the disease. Like there will be a two type onset of young onset of Parkinsonism. Park 1, Park 2. Autosomal dominant, that is form on the chromosome 4, and Park 2 it is autosomal recessive that form in the chromosome 6. 80% patient tremor predominant Parkinson's. 20% patients with akinetic rigid syndrome. So, what are the clinical features? So, discussing the clinical features of Parkinsonism, as you know that there are five important features that comes under tremor. Tremor, that is one of the best clinical features. So, one is asymptomatic distal peel rolling tremor. So, 4 to 6 hertz tremors. The frequency that comes, that is 4 to 6 hertz. Micrographia, maybe yes, there will be a micrographia. Brought on by concentration. ठीक है, resting tremors, akinesia, bradykinesia, rigidity. That's are the cardinal features of the tremor and rigidity and other. What are the other features like glabellar tap sign, lead pipe elbow or cogwheel rigidity, hypomimia, hypophonia. These all are the another types of the Parkinson disease. So guys, I will discuss about the what are the these all are typical type. Now atypical Parkinson's. Atypical type Parkinson's that are diffuse Lewy body dementia and multisystem atrophy. That's come with the alpha synucleopathies. And another is tauopathy, that progressive supranuclear palsy or cortical basal degeneration. So common symptoms like a rapid progression, no response to levodopa. That there will be a treatment, that is treatment of Parkinson. As we know that levodopa is one of the best drug, but hair will be not affected by giving this type of such drugs. Absence of tumor, and this is worst clinical features, that absence of tumor in the atypical type of Parkinson. What are the multi-system atrophy MSA versus progressive supranuclear palsy? There will be multi-system atrophy. What is this? So, but what is the pathogenesis? So, as like that, atypical alpha synucleopathy will be there in multi-system atrophy. which is the clinical features of ANS symptoms may be there, very, very there. Rapid eye movement, sleep disorder will be there. Bilateral akinetic rigidity, symmetrical symptoms, axial, that is also there. And in MRI findings, there will be hot cross bun sign. I repeat, hot cross bun sign in MRI findings. So what about the progressive supranuclear palsy? Here, the progressive supranuclear it is given by the Steele-Richardson syndrome, also called Steele-Richardson syndrome. Here, tauopathy will be takes place. Maximum bilateral symmetrical axial rigidity takes place. Wide-based gait, postural instability, supranuclear palsy, down gaze palsy, procerus sign will be there, in which the wrinkling and furrowing of the forehead takes place. Applause sign will be there, and here the MRI finding will be hummingbird sign or morning glory sign. These are MRI finding in these. What are the types of MSA? MSA, as we know that the multiple system PAC. Oh, PAC. P for Parkinsonism, A for autonomic, C for cerebellum. In autonomic, there will be a Syndrager syndrome. Syndrager syndrome. That is for the autonomic. One of the disease, that is a cortical degeneration. Neuropathy seen in elderly, clinical features with symmetrical triad here form. One triad here form. One triad is apraxia, myoclonus, cortical dementia. These are the triad for the corticobasal degeneration. Hemibellismus Parkinson features or basal ganglia involvement takes place. Alien limb phenomena. What is alien limb? Not using one limb and using the other limb. Here will be alien limb phenomena will be cortical basal degeneration is one of the most finding will be takes place in this. As no the half 50% part, that is Parkinson, is discussed well, and now we move further. That is most important topic, hemiplegia. Half part of the body paralysis, that is known as a hemiplegia. So it is a type of upper motor neuron degeneration of motor pathway. Here cortical pathway, extrapyramidal tract, and corticobulbar tract. So in cortical and extrapyramidal travel from the cortex to anterior horn of cell. In corticobulbar tract up to cranial nerve nuclei in brainstem. So causing hemiplegia related to cortex, subcortex, brainstem. So first I will discuss the cortex. What are the hemiplegia caused by the cortex? So corticospinal tract in cortex arise from motor cortex area for 30% fibers, premotor cortex 30% fibers, and sensory cortex area 3, 1, 2, 40% fibers. So guys, listen carefully. The frontal and parietal lobe is called contralateral hemiplegia will be takes place in frontal and parietal. In frontal, in parietal. Here there will be a what type of the contralateral hemiplegia will be take place. In temporal, there will be a Wernicke's aphasia supplied by M2 inferior division. And in occipital lobe, here you cannot hear the occipital lobe. Here it is supplied by posterior cerebral artery, incongruent contralateral homonymous macular sparing hemianopia. Okay, so occipital, temporal, parietal, frontal. These all are contralateral Wernicke's. These are the categories of the cortex type of the hemiplegia. So note one thing, that is for motor weakness, vessels involved. MI, M1, M2, ACA, that will be M1 stands for in sylvius fissure. M2 superior division. ACA anterior cerebral artery, that is occlusion will be takes place in the cortex will be hemiplegia takes place. What are the features of cerebral lobes? Frontal lobe, there will be a parietal lobe, temporal lobe. So guys, first of all, frontal lobe, here features of the cerebral lobes. That is a prefrontal cortex, frontal eyelid, two loop, two opposite sides, Broca's area, features of anterior cerebral artery occlusion. That is starts from the lower limb, then upper limb. Weakness will be there. Then next, gait issue will be there. Bowel bladder involvement will be there. Note bilateral ACA occlusion, periapathy, akinetic rigidity, or abulia. Okay, I repeat, severe apathy, akinetic rigidity, abulia will be anterior cruciate cerebral artery occlusion will be takes. Then discuss about the parietal lobe. Here the parietal lobe will be there. So area angular gyrus, ठीक है, Gestman syndrome, acalculia, anosmia, left to right disorientation, left to right disorientation. Yes, with agraphia, alexia with agraphia, superior parietal lobe apraxia. You can Google these words if you are confused. So no need to worry about these medical terms. It's simple. You Google. I also Google. You also Google and determine everything with learn. So dominant part will be superior parietal lobe apraxia and supramarginal gyrus with association with the area that is visual agnosia. These all are dominant. Now talking about non-dominant features, that is visuospatial disorientation, constructional apraxia, dressing apraxia, hemispatial neglect, severe form of agnosia will be formed. Inferior quadrant quadranopia is seen in parietal lobe lesion. Guys, discuss about the temporal lobe. Here the medial and lateral. Temporal lobe, here the medial, static and lateral. So about medial memory and epileptogenic. And in lateral auditory cortex, auditory associated area, auditory agnosia, and vernical area will be there. Superior quadranopia is seen in the temporal lobe lesion, limb cortex in temporal lobe. Kluver-Buschke syndrome is a part to be discussed very carefully. Superior quadropia is seen in a temporal lobe lesion with the limb cortex. So guys, here till now reach the part that is cortex is over and hemiplegia. Then we will move further aphasia. Here the phasia means meaning of aphasia. So fluency. So what are the fluent yes or no? If no, motor aphasia will be taking place. If yes, sensory aphasia. I will discuss about the first of all with the motor aphasia. Here the comprehensive positive or may not be positive. If positive, then check for the respiration. So here the repetitive, sorry, not respiration, repeated. If repetitive, comprehensive, transcortical motor aphasia. If not repeating, so Broca's aphasia. If comprehensive is absent, so repetitive, positive, so isolation aphasia, echolalia. If repetitive absent is global aphasia. These all are motor failure. Now discuss about the sensory aphasia. I will repeat and I will repeat. Don't worry about understanding. First of all, listen what I wants to say you. So about the sensory aphasia, there will be comprehensive present or comprehensive absent. If comprehensive is present, then repetitive. Yes, comprehensive is done. Repetitive is normal aphasia. If no repetitive, no repetition, then will be conduction aphasia. For comprehensive is absent, so repetitive is present, so transcortical sensory aphasia, like that. And if repetitive is absent, is Wernicke's aphasia. This tabulate form you have to remember very carefully. Note naming is affected by all aphasia. Naming is affected by all aphasia. Above that, I discussed the hemiplegia is subcortex or cortex. Now going to discuss about the subcortex and then brainstem. So cortical spinal tract pass through anterior two-third of the posterior limb of internal capsule in close associate with the corticobulbar fibers. So features that result into internal capsule lesions, that is contralateral dense hemiplegia, contralateral upper motor neuron cerebral palsy, hemisensory loss, homonymous hemianopia. These four are the features that internal capsule will be formed. So what are the brainstem reason for hemiplegia? So crossed hemiplegia is seen in brainstem lesions, contralateral hemiplegia plus ipsilateral cranial nerve palsy will be formed. So here the midbrain syndrome will be responsible for this. So cortical tract pass through the 3/5 of the crus cerebri. Vessels involved, it is a P2 segment, posterior cerebral artery, ventral midbrain syndrome, dorsal midbrain syndrome. These two are most important syndrome that is discussed. So here the Weber, Claude and Benedict, these syndromes are affected. Here the lesions that are base of midbrain, tegmentum, and here so base of midbrain features like ipsilateral of third nerve palsy, कॉन्ट्रालेटरल अपर मोटर हेमीप्लेजिया. दोस्तों सिंपल बात यह है कि वेबर सिंड्रोम में क्या होगा, इप्सिलेटरल थर्ड नर्व पैल्सी हो जाएगी, कॉन्ट्रालेटरल अपर मोटर न्यूरॉन का हेमीप्लेजिया हो जाएगा. क्लाउडे सिंड्रोम में टेगमेंटम जो लीजन में आ जाता है तो इप्सिलेटरल थर्ड नर्व पैल्सी वापिस से इसमें हुआ, कॉन्ट्रालेटरल एटेक्सिया हुआ है. ठीक है. डेंटाटो रूब्रो थैलामोकोर्टिकल फाइबर्स, ये सब क्लाउडी सिंड्रोम ना। बेनेडिक्ट सिंड्रोम होता है, बेनेडिक्ट टेस्ट नहीं कह रहा हूँ, बेनेडिक्ट सिंड्रोम होता है, याद रखना। तो फीचर्स में क्या होता है, वेबर टेस्ट पॉजिटिव रहेगा, क्लाउडे दिखेगा और कॉन्ट्रालेटरल हेमीपेलिस्मस दिखेगा। तो ये था अपना क्या कहते हैं वेंट्रल पार्ट का। अब डोर्सल की बात करते हैं तो पेरिनोल्ड सिंड्रोम और नॉर्थ नॉर्थ नाइजेल सिंड्रोम कहते हैं। अब पेरिनोल्ड में क्या आता है, इसमें टेक्टम में लीजन आ जाता है। आप काफ़ी अच्छे से देखना, उसमें देयर विल बी गिवन क्लियरली डायग्रामेटिक रिप्रेजेंटेशन ऑफ टेक्टम एंड ये देयर विल बी लेबलिंग आल्सो प्रॉपर्ली गिवन, सो नो नीड टू वरी अबाउट द। So, lesions about the tectum features vertical upgaze palsy, sun setting sign, overactive levator palpebrae superioris, lead retraction, Collier's sign, pretectal nucleus accommodation reflex present, pupillary reflex absent, convergence retraction, nystagmus, skew deviation of eye. These will are the Perinaud syndrome. There will be diagrammatic representative of the perinodal. You will remember afterwards. Now, Northanger syndrome. Here the ipsilateral lower motor nerve, third nerve palsy, gaze palsy, contralateral ataxia, superior cerebral Kudenka. Guys, now Pontine syndrome. Here the Pontine syndrome, medullary syndrome. These are the last topic for the today's, and further we will discuss next topic, that is a stroke. First, what are the Pontine syndrome? That is the Pontine syndrome. Here will be um, um, ventral pontile, dorsal pontine, lateral pontile. Here FSH, FGH, ASH. This is a tree for FSH, FGH, ASH. FSH stands for facial nerve, sixth nerve, hemiplegia. Sir, ipsilateral, contralateral. Ipsilateral gaze, contralateral. Last one is always stands for the contralateral. In the uh, ventral part. Here you can see dorsal pontile syndrome, fovile syndrome, that is a ipsilateral facial nerve palsy, gaze palsy, contralateral hemiplegia. Here lateral pontile syndrome, Mary Fox syndrome. Here ASH. So F is again for facial nerve, G stands for gaze palsy, H stands for contralateral hemiplegia, ASH. A stands for ipsilateral ataxia, S stands for contralateral pain and temperature, loss of spinothalamic tract, H stands for contralateral hemiplegia. Very dangerous, but you have to remember. Next, we move further. That is medullary syndrome, lateral medullary syndrome, Wallenberg syndrome, which is also known as a Wallenberg syndrome, or medial medullary syndrome. It is also called the Dejerine syndrome. So vessels involved here in the lateral medullary, that is V4 segment of ventral vertebral artery, is more than posterior internal carotid artery. Internal cerebral artery. So, cranial nerve, 5th, 7th, 8th, 9th, 10th, 11th, 13th. These all are cranial nerve being affected in the lateral medullary syndrome. 5th, spinal nucleus. So, ipsilateral loss of sensation of the face. NTS, there will be test sensation will be lost by facial nerve. Okay. So where will be for vestibulocochlear now in eighth now. So vestibular cerebral flares. So ataxia, dizziness, vertigo will be takes place. Ninth and tenth now vagus and glossopharyngeal now, that is resulting to the nucleus ambiguous, that is this arthalgia, dysphagia will be takes place as glossopharyngeal tongue will be affected. So dysphagia will be takes place, difficulty in speaking. 10th now as now vagus now, dorsal nucleus of vagus, it is autonomic features. And 13th now, which results into Horner syndrome. You can detail know about Horner syndrome in the ophthalmology. So sensory contralateral pain and temperature loss, spinothalamic tract will be affected. Cerebellum, ipsilateral ataxia, spinocerebral fibers, no motor deficit. So guys, medial medullary syndrome. So Dejerine syndrome. Here 4 M's. It is a trick to remember this. Motor nucleus of 12th nerve, ipsilateral lower motor node, 12th nerve palsy. Motor fiber of pyramidal tract, medial lemniscus, medial longitudinal fasciculus. So motor fiber of pyramidal tract, contralateral hemiplegia, medial lemniscus, contralateral posterior column findings, and medial longitudinal fasciculus internuclear ophthalmoplegia. Here is a diagrammatic represented. I will focus the diagram very focusly and more clearly. Here you can see that lateral and medullary syndrome very clearly. This stands for the pyramid spinothalamic tract. Here, this is dorsal spinocerebellar tract, descending nucleus and tract of fifth nerve. This this label and this part is vestibular nuclear. You can see clearly upper part is a dorsal part, lower part is dorsal part, upper part is ventral part, and you can see the 12th nerve here, the diagrammatic represent of the 12th nerve. Here the inferior olive 10th nerve, medial lemniscus, here the medial lemniscus, nuclear ambiguous, these I am talking about at that time, nucleus ambiguous. So medial longitudinal fasciculus will be here formed. So guys, thank you for watching till now, and next topic will be discuss stroke. So thank you. Jai Shri Krishna Bhagwan. Jai Shri Ram. Hare Krishna. Hare Krishna. Krishna Krishna. Hare Hare. Hare Ram. Hare Ram. Thank you for watching.